So for our first panelist, let's turn to Dr. Aloi. Dr. Aloi, you're going to be discussing for us the financial benefits of implementing glycemic management software. Joe, could you start by sharing what outcomes have been most significant since implementing glycemic management software in your health system?
Yeah, thanks, Paul, and thanks for the invitation to be here. What I'm outlining for you was one of the first quality improvement projects I started when I came to Wake Forest a few years ago. If you look at the bullet points, just to walk you through a little brief background, hospital admissions for DK and hyperglycemic emergencies have just been increasing over the last decade. And how best to treat them is still a little bit of an argument. A recent consensus guideline came out a few months ago, and I left the reference there for the interested reader, but it goes through everything from appropriate fluids to blood glucose targets to measuring ketones. We were interested in tackling our length of stay, which was hovering around 4 to 5 days, which historically you think you're doing good as a hospital system if you're closer to about 3.5 days. So we thought there was an opportunity there. This is one of the first things we looked at with EndoTool IV and our units, predominantly where DK is treated. That was in 3 specific units. The information I'm showing you is for about a year. And you can see with the EndoTool IV, we had about 190 patients. Standard treatment was a modified Yale protocol based in Epic. We didn't require at that point for all providers to use EndoTool. This was during the initial implementation. And our informatics team looked at 2 things. One was just the total cost of care for patients who started with EndoTool IV or those who were treated with standard treatment. And you can see that the length of stay was decreased by about half a day, which is pretty significant when you're looking at length of stay changes. If you look at total cost of care between the two, it was about $12 million. And that's really circling around just 2 hospitals in our larger system. The other thing I'd point out, and you're going to hear more about CMS and metrics about avoiding hypoglycemia, we looked back at a 3-month study period of this group, again, able to look at EndoTool versus non-EndoTool. And over that period, we had 55 events in the standard treatment. That's not 55 patients, but 55 events, but a slightly smaller group of patients. I think the patient group was closer to about 30 versus 1. And in that 1 patient, if the EndoTool protocol was followed completely, I think we would have avoided that. So what we concluded from this is that you can both enhance patient safety and you can save money. Particularly in our institution, these patients are housed in an ICU or a step-down unit, and there's always pressure to free up ICU beds and space, and it's obviously much more costly to care for patients in that space, and that's part of the driving of the cost savings. And I listed the reference for the abstract at ACE. This was all presented at the American Association of Clinical Endocrinology in May.
So you've had some outstanding benefits and a fantastic cost savings. I'm curious, any other impact on cost savings with improved glycemic control? I remember reading an article way back that if a patient has an episode of severe hypoglycemia, it's likely that they're not going to go home that day, but have to stay in the hospital another day. And there's also the cost of an episode of severe hypoglycemia. Any comments on that?
Yeah, both those are important factors. They're, when you look at a lot of big EMR data, it's sometimes hard to flesh out exactly what's driving what. But I'll tell you, we did have the opportunity, not in this study group, but in another look at the results of hypoglycemia in somebody in the unit. And clinicians tend to want to watch that person if they have a severe hypoglycemia. So it delays discharge from the unit. And we think part of this is getting to control quicker, and you're going to see some data about that, using EndoTool, getting patients to blood glucose goal much quicker than standard infusion rates. But part of it too is not having any hypoglycemia. There's not this leaving the patient on the drip longer or in the ICU longer. We had calculated using our informatics group, again, the total cost of care, and we estimated that an episode of severe hypoglycemia cost the patient about $12,000. That takes into account additional hospital time, the additional blood testing, and again, looking at sort of just total cost of care between those groups. And we saw an incremental change, in other words, higher cost of care for more episodes of hypoglycemia. We tried, but we have not been able to publish that because, again, when you're looking at these big data sets, the data is not, it's squishy. But there's clearly a relationship between hypoglycemia. Other things that people think about that's sort of on our radar, particularly in the heart patient, is wound infection and also any and need for dialysis. Because if you can avoid these glucose excursions, those tend to track pretty closely with improving those outcomes.
But any other thoughts from the panel on outcomes or observations that you'd like to share? Particularly, Tracy, you've had some great outcomes at Holy Cross with the implementation of EndoTool. Any insights you could share?
I'm just going to echo what he's already said. Especially in our CV population, we saw a significant decrease in adverse events related to diabetes and renal failure, and the ability to get them off of insulin faster, get them off drips and out of the unit even faster. Our wound healing has certainly not been impacted at all, and overall length of stay in our CABG population is down. Now, as regards to other platforms and methods, DKA was a significant cost savings for us. Just the fact that we were able to get a DKA patient controlled in under 10 hours and get them out of the ICU faster. Our ICU utilization and length of stay is the best it's been in a long time. We're able to shave off our length of stays, the average length of stay is down to 3.2 days. So we see the same outcomes. We've used it for 18 years now.
Excellent, excellent. The other comment I would make is that a lot of times patients must stay in the ICU when they're on an insulin infusion. And the ease of using an insulin infusion with EndoTool allows some institutions to actually treat their patients needing an insulin infusion in the step-down unit rather than the ICU. Any of the panelists have that experience where you're able to actually treat your patients outside the ICU on an insulin infusion?
I would start by saying that's a study ongoing with the emergency room to keep these patients in an OBS unit, clinical decision unit, partly because of expanding EndoTool use down into the emergency room and the overall experience we've had. So we're looking at that literally as we speak. Our ED just went live mid-October.
Yeah, there are some of our customers that actually will use insulin infusions on the step-down unit now, or they use it anywhere in the hospital.
No, just echoing that we use it anywhere in the hospital. We use ours in the ER, we use ours in the birthplace, we use it in step-down units, we use it on med-surg floors, so we pretty much.
Does that lessen the need for an ICU stay for these patients then, for a DKA patient, for instance?
I think it does. In terms of we do transfer them out. It means if you're severe DKA patients, bicarbs of like 2, and we're surprised they're still awake, they tend to be in the ICU, but your relatively stable DKA patients, whatever that may look like at your facility.
Excellent.